Welcome to the lecture on CVA overview. This part of the lecture is going to look at the general overview of cerebrovascular accident, or CVA, and then there will be a second lecture that talks more about specific vascular syndromes. So this one is kind of the overview of stroke, or CVA. Our objectives: we want to look at what the initial presentations are of CVA. We'll talk about risk factors, and the reason we're doing that is as physical therapists, we're managing patients. We're involved with patient-client management. So you might be working with patients that have multiple risk factors for CVA, and I do think it would be important to talk to them about these risk factors so that we can encourage them possibly for some behavior or activity modification. We'll look at different types of CVA pathophysiology, what type of problems can be going on that'll be causing stroke. We'll discuss the imaging and medical management considerations for acute CVA as well. Information from this lecture comes primarily from Chapter 15 of your O'Sullivan textbook. FAST, here's what you're talking about if someone is having an acute CVA. If you've listened to the podcast, Dr. Osborne talks about this in some detail. So FAST is face drooping, arm weakness, speech difficulty, time to call 911. What exactly is a CVA? It's a cerebrovascular accident. I've heard of it also called a brain attack, and reason for that nomenclature is that may get people to think about it a little more seriously, kind of like we think of a heart attack as something serious. If you think of a stroke as a brain attack, that makes it seem a little bit worse in a way, or something deserving of prompt responses or quick medical attention. What happens is you're going to lose neurological function because of a loss of blood flow to the brain and eventually loss of oxygen, other nutrients as well. This loss of blood supply can be either due to blockages or bleeding, and we'll talk more about that in a bit. For your history and examination in CVA, we need to go back to materials you've learned before, and remember that CVA can mimic other conditions. Probably the two more common ones it could mimic would be a Bell's palsy or an acute vestibular syndrome, and we'll discuss ways to differentiate between those two. Someone who talks about having the worst headache of my life, that is highly suggestive of a subarachnoid hemorrhage, or SAH. For a stroke, you're usually going to have unilateral symptoms. If you have bilateral symptoms, that's suggestive that possibly the brainstem is involved or there's massive cerebral involvement. And both of those would be correlated with worse outcomes, worse mortality. So again, we're usually talking about unilateral symptoms. This is review material from materials that have been presented before, and we've also talked about it a bit on the podcast. But when you're distinguishing between Bell's palsy and stroke, a key area to look at would be the forehead. So if it is a stroke, the forehead area is going to be spared, versus Bell's palsy, that entire side of the face is going to be involved. We also need to separate a possible stroke from an acute vestibular syndrome. We covered this a little bit in neuroanatomy. You can use the head impulse nystagmus test of skew, which is 100% sensitive and 96% specific for stroke. If you forget everything else, look at doing your head impulse test. Remember, a positive head impulse test means that there is a peripheral problem. The head impulse test, the person's neck is flexed about 20 to 30 degrees. They're focusing on your nose, and you give them a quick turn about 20 degrees to the left, quick 20-degree turn to the right, and they need to remain focused on your nose. A positive test would be kind of that catch-up saccade. So if they do have a positive test, you are actually thinking that a likelihood of stroke is lower than that, or probably not there, because a positive head impulse test tells you it's a peripheral problem, whereas a stroke is a central problem. I've attached links to some of the materials for this. I think you also have that initial study about hints. So file that away. This will come back also during the vestibular portion of the course. But the head impulse test is something you should absolutely, even if you don't work with vestibular or whatnot, this test is useful, keeps coming up again and again. So know the head impulse test, know that a positive test means it's a peripheral problem. So what's the scope of the problem with stroke? Almost 800,000 new cases per year, which works out to every 40 seconds in the United States. One death, a little bit more often than every 4 minutes. Costs us about $40 billion annually. Two different main types of or categories of stroke. Ischemic, that's going to be where there's a loss of blood supply because of some type of a blockage. Or hemorrhagic, which indicates that the loss of blood supply is due to a bleed. And we'll talk in greater detail about those different types. I've linked here on the PowerPoint a document from Heart Disease and Stroke Statistics. This is the 2018 update. Many of the data and figures you're going to see in the next few slides come directly from this source. I use this source because it's got updated 2018 information. This is going to be more current than what's in your textbook. Here's our list of risk factors for CVA. Your text indicates certain ones, and the reference from the 2018 update indicates certain ones are modifiable and not modifiable. There's probably some wiggle room. You could argue that hypertension could potentially be modifiable, as could some of these others. So how important is it to know whether something's modifiable or not modifiable? May not be critical to know, but you do want to know what these risk factors are, and the ones that we say are modifiable, absolutely want to be able to have conversations with patients about these. Smoking seems to be one of the hugest, one of the biggest risk factors in terms of CVA. Current smokers are 2 to 4 times increased risk of stroke. And as we mentioned on the podcast, doesn't matter when you quit, your kind of risk curve starts shifting back towards normal right away. So you could have 10, 20-year history of smoking, you quit and you abstain from smoking, and your risk factor right away starts to go back towards normal. So you have that smoker, again, no one likes to be lectured at, but really if there's anything that you can plug that person into to help with quitting smoking, you're helping them reduce the risk of having a stroke. Smoking seems to be the most important risk factor in preventing subarachnoid hemorrhage, or stopping smoking, that is. So subarachnoid hemorrhage, as we'll see, has a pretty high mortality, means that those people that sustain a subarachnoid hemorrhage are at a high risk of death. So if you can get someone to stop smoking, you've really improved their, survival, or you've lowered the risk of dying from a subarachnoid hemorrhage. Modifiable risk factor activity is a huge one. So inactivity is associated with a great risk of stroke. For females, any physical activity gives them a 50% reduction in stroke risk. This protective effect was not observed in males. Doesn't mean we don't tell males to exercise or get activity, but no, if you have a sedentary female not doing anything, and you get them even on something as simple as a walking program, you have effectively given them a 50% risk reduction in having a stroke. Additionally, across both genders, keeping fit in terms of aerobic fitness and muscle strength gives you a lower risk of stroke, and that seems pretty intuitive. Nutrition is a big one. We mentioned on the podcast that according to the APTA, our practice as physical therapists does include talking to people about nutrition. Doesn't mean we're nutritionists or dietitians, but we can counsel people on the value of nutrition as it relates to overall health. Soda is a big no-no. It's bad. And Dr. Osborne and I on the podcast talked quite a bit about how we both like sodas, and we probably should look at cutting down on these. And it's not just regular sodas, it's also diet sodas. And diet sodas actually give you a huge increased risk in hemorrhagic stroke. I'm not sure if it's the artificial components or what that is, but sodas, both regular and diet, give you an increased risk of having a stroke. Now, conversely, if you're looking at either the Mediterranean style diet and or having a high level or a high number of servings of fruits and vegetables, you're going to lower your risk of stroke. Calcium and dairy seem to also provide risk reduction for having a stroke. So soda's bad, fruits and vegetables good, Mediterranean diet good, and dairy intake and calcium seem to have beneficial effects as well. There's some other risk factors as well. Women, there's kind of two areas they need to be aware of. Early menopause ups the risk, and estrogen use and oral contraceptive use ups the risk. Dr. Osborne talks on the podcast a bit that current oral contraceptives are better researched, and the risk with these is not as high as it used to be in the past. There's psychosocial risk factors, and this comes up throughout everything. We've talked about psychosocial as it relates to chronic pain. You're going to see, basically, we're treating people at the end of the day, and your mind has a huge effect on your overall outlook and your overall health. So people who are depressed have a twofold increase in risk of stroke. And this part makes sense. A third of patients develop depression after a stroke. So let's say you're working with someone who's had a stroke, you do want to screen them for depression because it would make sense. They've sustained a large neurologic insult that's changed their life completely. Depression would be normal and fairly expected. So don't neglect considering depression after stroke. Sleep seems to have some risk factors associated, and interestingly enough, sleeping too long or not enough gives you an increased risk of stroke, whereas that middle ground, that 6 to 7 hours, according to the data, is safest. Now, everyone's different. Everyone's sleep requirements are different. I just found this interesting that when you look at group data, 8 to 9 hours and 5 to 6 hours are increased risk of stroke, but that 6 to 7 hours has the lowest risk. So let's look into the actual pathophysiology of CVA. You can split them into ischemic or hemorrhagic, and by far the most common is going to be ischemic. The 2018 update from the document that I posted on the PowerPoint says that ischemic strokes make up about 87%. Your textbook's going to indicate 80%. That's not going to be a trick quiz question or anything. The big key here is that by far the vast majority of strokes are going to be ischemic. Hemorrhagic strokes are going to make up 13% of strokes, with the intracerebral hemorrhage being 10% and the subarachnoid hemorrhage being 3%. Two different types of ischemia. So we're talking about an ischemic stroke where there's a blockage of blood supply or blood flow. There's a thrombus where platelets aggregate on plaques. So this is when you think of kind of plaque buildup in the vessel walls, and over time it gets to the point where blood just can't flow by. Versus an embolus where bits of matter have formed elsewhere, things have clumped together, and then this kind of clot travels to the cerebral arteries. You're probably familiar with the term pulmonary embolus. That's what happens in the lungs, but an embolus can also happen in the cerebral arteries where it would cause a CVA. You can have low systemic perfusion due to cardiac failure or blood loss. This would give you massive global and bilateral deficits. We're not going to focus too much on this. This would be pretty rare to see clinically. For our purposes, we're most interested in the thrombus and the embolus. And if you need a little bit more information on these, refer to your text, page 647. Little diagram from the text. These are the preferred sites for plaques. I'm not asking you to memorize these. Here's your circle of Willis and your vascular supply. So the areas in red are where it's most common for plaques to build up. We'll talk more later in the other audio lecture on the vascular syndromes, what you see most common clinically. This picture is just for your reference. So let's talk about thrombotic strokes. These are the most common types of stroke, and you get the atherosclerosis of blood vessels. And the sites are going to be, the more common sites are going to be the larger vessels. These types of strokes occur gradually, and that makes sense. This is an ongoing kind of buildup of plaque. Over time, those vessels narrow because of these plaques. So this is not anything abrupt. This is kind of the ticking time bomb, for lack of a better term. So you're going to see this more often in older persons that have some other risk factors, especially atherosclerotic heart disease. These strokes are not associated with exertions, and they can happen when the person's at rest. So this is someone's just chilling, hanging out, feet up in the lazy boy, and it happens. reason I bring that up, that's going to be in sharp contrast to hemorrhagic strokes, which we'll talk about later. Those are usually associated with exertion. So thrombotic, usually elderly patient, this builds up over time, not associated with exertion. A couple pictures just showing examples of thrombolytic CVAs and kind of what's going on there. So a stroke that's the result of an embolus is a clot that's formed elsewhere. It's dislodged and travels to a cerebral blood vessel where it then becomes trapped and interrupts blood flow. These are typically going to affect the smaller vessels. This is what you'll see in like the middle cerebral artery type of stroke. These have a sudden onset and they're associated with cardiac disease. These can also happen after a recent heart attack. So again, we've got someone that has cardiac disease or that has cardiovascular risk factors is automatically going to be at risk for a stroke. So we're going to file that away and remember that, because I hate to use that term ticking time bomb again, but that's what happens. These people have cardiac disease, maybe not well treated. Things are going on behind the scenes that they may not be able to feel or see, but it's setting them up to have a stroke. This slide just gives you a picture, a couple picture diagrams of what's happening with a stroke from an embolus. So we talked about strokes that arise from thrombus, embolus. These are pretty much think that the blood vessel is blocked for whatever reason. So you have a localized blockage, and that's again most common. Between 80 to 87% of strokes are going to be ischemic, either thrombus or embolus. Let's switch gears and talk about hemorrhages. These are going to be bleeds. So your most common is intracerebral, but you can also have subarachnoid. And these two are classified based on where the rupture and the bleeding is occurring. Picture to show you kind of an example of hemorrhagic strokes. And you see on the picture, kind of on that right side of that first picture, you just see that reddish color. So you've got a blood vessel that's ruptured and it's just bleeding out into the area. So that looks much different than an ischemic type of a stroke. This is a diagram of intracerebral hemorrhage, so you can take a look at that and see we've got the, again, bleeding out into the brain. Picture of a subarachnoid hemorrhage, and we see the bleeding happening into the subarachnoid space. So beyond the difficulties or the problems we're going to have from the bleed itself, now by bleeding into the subarachnoid space, we may also have a pressure issue that's happening because the bleed's happening into a confined space. Hemorrhagic stroke involves bleeding into the brain tissue after a blood vessel has ruptured. This is going to result in edema and compression of brain tissue. As I previously mentioned, you've got kind of bleeding into a confined space, putting pressure on areas. This can be fatal very quickly, and it makes sense. You're bleeding out. It's going to have systemic effects as well as very dire effects on the brain tissue that's being compressed. Now, these are associated with exertion and activity. Patient will say, I feel like I'm having the worst headache of my life. I've worked with patients who have had hemorrhagic strokes. A lot of times these are going to be your younger patients. So we thought about the ischemic type of strokes. We said these usually, especially for a thrombus, has been building over time, slow and steady. These hemorrhagic strokes can come up at the drop of a hat. So someone is performing, is exercising, playing in a sport. Maybe they had a congenital defect, they had a weird anastomosis, their walls are weak and their blood vessels, and they just drop. And no one could see it coming. It's not necessarily anyone's fault. It was a weakening of the blood vessels. Unfortunately, the mortality in hemorrhages is much higher than ischemic strokes. In terms of overall mortality, source I saw said the intracerebral might be worse than subarachnoid. Don't worry about memorizing that too much. Basically know that hemorrhagic stroke has a worse mortality than an ischemic stroke. A third to a half of intracerebral hemorrhage patients or patients with intracerebral hemorrhage die within the first month. So that is a very high mortality. You can see why that could be. They're bleeding out, there's pressure on the brain tissue. If they don't get medical attention right away, their chances of survival are not good at all. Now, on the positive side, someone who sustained a hemorrhage actually has the same functional outcomes as someone who had an ischemic stroke. So if that person can survive, their prognosis is just as good as someone who had an ischemic stroke. So for us as PTs, you're in the clinic, you review the chart. Oh, someone had a hemorrhagic stroke. Doesn't mean that they're going to have a worse functional outcome than someone with an ischemic stroke. You look at what happened to kind of know the history, know what's going on, but for your overall prognosis, it's really not going to change. Both patient subgroups have the same chance of getting better, so don't think that someone who had a hemorrhagic stroke is destined to have a worse outcome. Here you can review your text if you want more information on imaging. Talks a little bit about CT, MRI, MRA. CT does seem to be most commonly used and is a little bit quicker. And the big thing with imaging, especially acutely, that we want to know is this from an ischemic stroke, or is there ischemia, or is this hemorrhagic? Does a person have a clot that needs to be busted, or are they bleeding out, and do they need any type of emergency surgery to alleviate pressure on the brain or treated to kind of stop that bleeding? So if it's ischemic, the person may be a candidate for TPA, which is tissue plasminogen activator. In quotes I have here, it's the clot buster. So basically, if you have a clot that is preventing blood flow, this medication given within the first 3 hours has been shown to be very effective. Most references indicate that the 3-hour window is most appropriate for treating ischemic strokes. I did see some debate in the literature whether this window should be extended, and some authors suggest that maybe TPA is not being used as much as it could be. Maybe it's underutilized because of problems in timely and accurate diagnosis. As previously mentioned, this medication, TPA, is not going to be appropriate for hemorrhagic stroke. You're not trying to thin someone's blood who's bleeding out, or you're not trying to prevent clotting. You're actually trying to encourage it if someone is bleeding out. So TPA would not be appropriate in a hemorrhagic stroke. And this would be why you're really not medically going to see someone with an acute stroke treated until they know what type of stroke it is, so they can initiate appropriate treatment. Let's talk a little bit about transient ischemic attacks, or TIAs. This is neurologic dysfunction from focal cerebral ischemia, so this would be an ischemic event not associated with permanent cerebral infarction. So the key here is that this is transient. You have symptoms and then they resolve. A couple big take-home points here. A TIA is associated with an increased risk of eventual stroke. Makes sense. You basically had one and the clot resolved itself. These are typically defined as lasting less than 24 hours, although I did find an article in the literature that suggested less than 24-hour window may be erroneous. I wanted to put that there so you guys know it's there. Most people in general are going to say 24 hours or less is a TIA. Just know that even that operational definition could be debatable. Sometimes people tend to shrug off TIAs. Oh yeah, I'm better, I'm fine. Again, they're going to have a stroke most likely if they don't change what's going on. Their risk for another neurologic event or risk for an eventual stroke is much, much higher. So these are just not something to take lightly. For us as PTs, we may take it lightly because we probably don't have to do much treatment for these patients, but I would argue that here's where that life coaching or that overall health and wellness coaching comes in, that while we don't want to scare someone, I think we need to honestly and openly tell them, hey, this is a big warning sign for stroke. How are you doing managing your diabetes? How's your blood pressure? Are you getting in regularly to see your doctor? If we don't have those discussions, we haven't really helped them see that they need to make some changes. Box 15.2 from your text talks about pharmacological management of stroke. You don't need to memorize these. I want you, though, to be familiar with them, especially look at the side effects. So you've got insomnia, nausea, You may have weakness with some of these. So if you're working with someone, you think that they're getting weak or they seem tired, is that something that's going on with their body, or is that a medication side effect? So it's something to keep your eye on. For anticoagulants, those I would argue you probably do need to know very well because they're associated with so many other risks. So someone that's on active anticoagulation is at higher risk for bleeds. They need to consider what they're doing in terms of shaving. They need to watch out for any falls where they could sustain any types of bleeds. There's also some dietary restrictions in terms of foods rich in vitamin K that they need to watch out for. So look at the anticoagulants just because that is a big safety issue that you want to be very familiar with. You may need to know about clotting times, INRs, those types of things, just to be a well-informed medical practitioner or clinician. So in this lecture, we talked a little bit about the epidemiology of stroke. So about 800,000 cases per year, 1 every 5 seconds. Someone dies close to every 4 minutes from a stroke. A lot of risk factors. Some are not modifiable, but there are a large number of modifiable ones. And I'd say the biggest ones there seem to be smoking, diet, and activity level. So at the end of the day, we can't control what happens to us. We can just put the odds in our favor. So as you're working with patients, if you see these modifiable risk factors, do some education or try and steer them in the right direction. We looked at some diagnostic considerations for stroke, the pathophysiology, is it ischemic versus hemorrhagic. For mortality, remember that hemorrhagic strokes have a much higher mortality than ischemic, but both ischemic and hemorrhagic have the same functional outcomes. Imaging is important to know what type of stroke it is. If it's an ischemic stroke, TPA treatment within that first 3 hours may be recommended or indicated. TIA is a huge risk factor for eventual stroke down the road, so while you may not be treating someone long-term who's had a TIA, definitely educate them, give them the counseling needed to either modify behaviors and, maybe even more importantly, make sure they're following up regularly with their physician. Be aware of medications that patients who have sustained CVA might be taking, and with a special emphasis on anticoagulation. Know what's going on there. You're going to encounter anticoagulation not only in patients with CVA, but after total joint replacement, maybe in the acute care setting. So I'm not saying that you have to be an expert for neuroclass in all pharmacology, but you need to know anticoagulation. So that's the end of Part 1, Introduction to CVA. The next audio lecture will go into the more specific vascular syndromes and what we're actually more likely to see clinically.